Welcome back to the deep dive. We spend a lot of time on this show analyzing these um, really complex systems,
Yeah.
global supply chains, tech stacks, the history of banking.
hmm
But today, we are looking at perhaps the most complex, high-stakes system upgrade in existence.
hmm
And the crazy part, it all happens in about 60 seconds.
It is the original system upgrade. And if it fails, there is no Control-Alt-Delete.
Exactly. We're talking about the delivery room, and specifically we're analyzing the medical protocols that govern, the first few minutes of a human life.
Right.
We have a stack of source material here, clinical guidelines, resuscitation flowcharts, equipment lists that paint a very different picture than what you see in the
Yeah,
movies.
absolutely. The
Yeah.
movies give you the romance, right? The sweat, the push, the cry, and then this, perfectly clean bundle of joy.
Yeah.
But the documents we are looking at today reveal a highly technical, almost militaristic checklist designed to manage what is arguably the most dangerous physiological event any of us will ever go through.
That is a heavy statement. The
Yeah.
most dangerous event. But when you look at the biology, it it really holds up.
It does. I mean, think about it for a second. For 9 months, a fetus is essentially an aquatic creature. They're submerged.
Right?
The lungs are filled with fluid. They're not doing any gas exchange at all. The placenta is the entire life support system. It's the lungs, the kidneys, the digestive tract,
Everything.
everything. Then, in a matter of moments, that lifeline is cut. And the baby has to transition from fluid to air, clear that fluid out, and completely reroute its entire circulatory system.
Source material uses a phrase for this that I found really grounding. They call it cardiovascular adaptation.
It sounds so clinical, doesn't it? But it's the perfect description. It's a mechanical switch. The pressure in the lungs has to drop. Blood flow has to literally reverse direction in certain arteries. It's a massive plumbing overhaul.
And the core thesis of these documents, it seems to be that when things go wrong in those first minutes, it's rarely because the baby is, sick in the traditional sense.
Right, and that is such a crucial distinction for you to understand. The protocols explicitly state that at birth, if a baby isn't breathing or the heart rate is low, it is usually not some serious organic disease. It's a failure of that adaptation. It's a plumbing issue, not a broken pump,
Which means it's fixable.
if you act fast. And that is why the delivery room of the 21st century, which is described right here in our sources, looks less like a bedroom and more like a spaceship cockpit.
I was so struck by that image in the file. You have the standard bed, sure, but then you have this heated reanimation table.
Yeah.
You have suction units, oxygen blenders, high-tech monitoring screens. It's this intense juxtaposition of a raw biological event and this sterile high-tech safety net.
And that safety net is activated the second the baby arrives. We call this the golden minute.
Okay, so walk us through this. The baby is born. The clock starts. According to the protocol, what is the absolute first priority?
You might think it's checking the heart or cutting the cord or handing the baby to the mother, but strictly speaking, for survival, it's the environment, specifically thermal regulation.
Keeping them warm.
It sounds so basic, but it is critical. The source lists drying and early skin-to-skin contact as just non-negotiables. A wet baby loses body heat at a catastrophic rate through evaporation.
Wow.
If they get cold, their metabolism crashes, they get stressed. And that cardiovascular adaptation we talked about, it just grinds to a halt because the baby is using all its energy just trying to stay warm.
So when you see the nurses aggressively rubbing the baby with warm towels, that's not just to clean them off.
No, that is a medical intervention. They're stimulating the baby and stopping that heat loss.
No.
The equipment list even mentions aluminum foil in some contexts, like wrapping a baked potato, essentially, to keep that core temperature up.
Right.
You're trying to conserve every single ounce of energy for the hardest task, breathing.
Speaking of breathing, let's talk about the airway. This is where I think popular culture has really misled us. In every movie from the 90s, the doctor immediately jams that blue bulb syringe into the baby's mouth and nose.
The suction everything approach.
Right.
Yeah.
But the modern protocol here is actually much more nuanced.
It is. And it's a great example of how medicine evolves based on data. The old school method was to suction everyone, but the data showed that aggressive suctioning can actually trigger a vagal response. It can stimulate a nerve that slows the heart rate down.
So you could be causing a problem.
We were causing bradycardia in perfectly healthy babies. So the new rule is, look at the amniotic fluid first.
So it's a visual check.
Exactly. If the fluid is clear and the baby is starting to breathe or cry, you do not suction. You leave them alone, let them cough it out.
But if the fluid is not clear,
Then it's a red alert. If the fluid is greenish or reddish, or if there's meconium present, which is the baby's first stool, then the protocol flips completely.
because if they inhale that stuff,
It's a disaster. It causes aspiration pneumonia. Essentially, the baby inhales thick, sticky waste into their pristine lungs. It blocks the airways, causes massive inflammation. It can be fatal.
so what's the move?
If the fluid is dirty, the team immediately suctions the mouth, nose, and throat. The source even notes that if necessary, they'll pass a tube to suction the stomach just to make sure none of it can be regurgitated and inhaled later.
It's a split-second decision tree then. Clear fluid, hands off. Dirty fluid, get in there immediately.
Precisely. And while this is all happening, the cord is kept clean and dry, and the team is moving to the assessment phase.
Which brings us to the test that none of us remember taking, but we all hopefully passed. The APGR score.
The famous APGAR, it's everywhere.
I've always just thought of it as a number, like, oh, he was a 9. But looking at the breakdown, it's actually a really clever communication tool.
That was the original intent by Dr. Virginia Apgar back in the 50s. Instead of a nurse writing a whole paragraph, they could just say APGR7, and everyone knew exactly what that meant. It's an acronym.
Let's decode it, because there are some surprises in here. 5 categories, each scored 0, 1, or 2. So first is A.
A is for appearance, skin color. You want a 2, which is pink all over.
Which I imagine is rare in the first 60 seconds.
Very rare. Almost impossible, actually. Most babies get a 1 here because of something called acrocyanosis, blue hands and feet. The body is smart. It prioritizes the core, the heart and brain, so the extremities get less blood flow at first.
And a 0 would be blue all over.
Blue or pale, yeah.
Okay.
P. P is for pulse. This is the big one. Absent is 0, but the cutoff for a good score is 100 beats per minute. Over 100 is a 2. Under 100 is a 1.
That 100 number comes up a lot in these documents.
It is the magic number in neonatal care. If the heart rate is over 100, you're generally stable. If it drops below 100, we worry. If it drops below 60, we act.
Got it. Next is G. grimace.
Which is a funny word for it. It's really reflex irritability. Basically, how responsive is the nervous system? You flick their foot, do they react? A floppy baby is a 0. A little face is a 1. A sneeze, cough, or pulling away, that's a 2.
A is activity.
Muscle tone. Are they limp, which is a 0, flexing a little bit for a 1, or actively moving for a 2? You want to see a baby that looks like a little boxer, arms up, legs kicking.
And finally R. respiration.
Absent is 0. Slow or irregular is 1. And that loud, vigorous cry that parents love, that's a solid 2.
So you tally these up at 1 minute and again at 5 minutes. What's a passing grade?
The source says 7 and above is normal. A 10 is actually really hard to get right away because of the skin color thing. So an 8 or 9 is fantastic.
But it's lower.
4 to 6 is fairly low, needs attention. 3 and below is critically low. That's a baby who needs immediate resuscitation.
The source has a specific warning about that 5-minute mark, doesn't it?
It does, yes. If the score is still 6 or below at 5 minutes, you have to keep repeating the test. A consistently low score at 5 minutes is a serious warning sign. It correlates with a risk of hypoxia, oxygen starvation, and potential long-term issues.
That is terrifying. But before parents listening get too anxious, the source material does offer some statistical comfort.
It does. It's a good reality check. The data shows that up to 10% of newborns need some kind of help breathing, maybe just a little oxygen or stimulation. That's pretty common. But only 1% need immediate major medical care.
So for 90% of us, the biology just works, the switch flips.
Exactly. The machine works as intended.
Okay, so let's assume we are in that 90%. The baby is pinking up, crying, APGAR is an 8. The medical team shifts gears from emergency response to pit crew.
It really is a pit crew. While the parents are having that amazing emotional moment, the team is running this parallel track of routine maintenance.
What's on that checklist?
Vital signs, of course. Temperature, heart rate, respirations, then measurements, weight, length, head circumference. But then there are the preventative measures that happen almost automatically.
Like the eye care. I saw antibiotic ointment on the list. Is that standard?
It is. It's to prevent eye infections from bacteria that might be in the birth canal. Even if the mother tested negative, it's often just a blanket safety policy because the consequence blindness is so severe.
And the vitamin K shot. I know this comes up in parenting forums. Why is that in the protocol?
Because newborns are naturally deficient in vitamin K, which is essential for blood clotting.
Yeah.
Without it, there's a small but very real risk of spontaneous bleeding, even in the brain. One shot just eliminates that risk entirely.
Simple. Effective.
And finally, the bath. But notice the timing. It's usually after stabilization. The days of whisking the baby away immediately to scrub them down are mostly gone. We prioritize warmth and bonding first.
Okay, so that is the happy path. That's a good day. But we need to talk about that 1 to 10%, the moments when the adaptation fails.
This is where the source transitions to neonatal resuscitation, and this is where the training really kicks in.
The philosophy here seems really specific. In adult CPR, it's all chest compressions, chest compressions. But for babies, the source says, ventilation is the most important and effective intervention.
That goes right back to the plumbing versus pump analogy. Adults usually have a cardiac arrest because their heart stops a heart attack. Babies usually have a cardiac arrest because they run out of oxygen. Their heart is fine, it just stopped because it ran out of fuel. If you fix the oxygen, the ventilation, the heart will usually fix itself.
So they use an ABC protocol. Let's walk through it. A baby is born, they aren't breathing well. What's step 1?
Initial evaluation. You look at color, tone, breathing. If it's bad, you move to stimulation.
How do you stimulate a newborn? You don't shake them?
Never, ever shake a baby. The protocol is very specific. Back rubs or foot flicks.
Foot flicks.
Literally flicking the sole of the foot with your finger.
Yeah.
You're just trying to annoy the nervous system enough to trigger a gasp. You want them to get mad and take that first deep breath to cry.
Okay, so you flick the foot, no response. The baby is still limp. We move to A for airway.
You position the head. The source says slightly extended. You don't want it too far back or tucked too far forward, or you pinch the soft windpipe. It's called the sniffing position. Then you suction the mouth and nose to clear the path.
Still no breathing, or the heart rate is under 100. Now we move to B.
Breathing. This is the intervention point. You don't wait. You start positive pressure ventilation.
This is the mask.
Yep, usually a mask connected to a bag or a neopuff. You place it over the nose and mouth, create a seal, and squeeze air into the lungs. You are manually inflating the system, forcing those fluid-filled sacs open.
There's a curious note here. If masking continues, a gastric tube is inserted after 2 minutes. Why?
Physics. When you blow air into a baby's face with a mask, some of it goes down into the stomach. The stomach inflates like a balloon.
We would press up on the lungs.
Exactly. It presses up on the diaphragm and prevents the lungs from expanding. So if you're bagging for more than a couple of minutes, you have to put a tube down to vent the stomach. Literally let the air out so you can keep ventilating effectively.
Okay. So we are ventilating. We are doing the breathing.
Mm-hmm.
But the monitor shows the heart rate is dropping. It's crossing that magic line.
If effective ventilation is happening, meaning the chest is rising, and the heart rate drops below 60 beats per minute, that is the critical threshold for C circulation.
Less than 60. That's when you start chest compressions.
Yes. And notice the condition. Despite effective ventilation, you have to prove you are getting air in first. If the heart is stopping from low oxygen, pumping blood with no oxygen in it won't help. You oxygenate the blood first, then pump it.
That is a fascinating distinction. And the rhythm is different than for adults, isn't it?
It is. In adults, it's fast, like 30 compressions to 2 breaths. In newborns, the ratio is 3.1. 3 compressions, 1 breath. 3 compressions, 1 breath.
Why that ratio?
Because, again, oxygen is the priority. We need to make sure we're pausing frequently to get that breath in. We're driving oxygen into the lungs, then pumping it to the brain.
And the technique. I see 2 thumb versus 2 finger.
The source is explicit here. Prefer the 2 thumb technique. You wrap your hands around the baby's torso, thumbs on the sternum. It generates higher blood pressure, and it's less tiring for the doctor than just poking the chest with 2 fingers.
So imagine that scene. You have a team ventilating, someone doing compressions. It's intense.
Yeah.
But what if?
Yeah.
What if it's still not working? The heart rate is still flatlining.
Then, and only then, do we open the final door. D drugs.
This is the last resort.
It is. The primary weapon here is adrenaline or epinephrine.
What does that do?
It's a powerful vasoconstrictor. It clamps down on the blood vessels to shunt whatever blood flow is left to the vital organs, the brain, and the heart. It tries to kickstart the engine.
The dosage is. It's microscopic.
10 to 30 micrograms per kilogram. It's tiny, but in a 3-kilogram body, it's incredibly powerful. It can be given through an IV or even down the breathing tube if you have to.
The kit also lists volume expanders and dextrose.
Volume expanders like saline are for if the baby lost blood and is in shock. You need to refill the pipes. Dextrose is just sugar. If the baby has run out of energy, hypoglycemia, the heart physically can't pump. You give them fuel.
There is one drug on the list with question marks next to it. Sodium bicarbonate.
Yeah, that's the medical community kind of debating with itself in real time. Sodium bicarbonate treats acidity in the blood, but the evidence for using it in newborns is controversial. It can have side effects. Those question marks tell the doctor, think twice, is this really necessary? Have you tried better ventilation first?
It really highlights that even with all these protocols, there is still so much judgment involved.
Absolutely. It's an algorithm, but it requires a human to interpret the data.
So let's say it works. Adrenaline kicks in, heart rate jumps to 120, the baby turns pink, the storm is over.
The resuscitation is over, but the work isn't. The protocol shifts to post-resuscitation care.
What does that look like?
Close observation. You need an IV line. You need to monitor blood sugar constantly because that stress burns through glucose reserves so fast. And temperature control becomes even more vital. You can't let them crash again.
You know, reading through this, I keep coming back to the tools. We mentioned the reanimation table, but the list includes laryngoscopes with size 0 blades, tracheal tubes that are 2.5 millimeters wide.
It's precision engineering. A 2.5 millimeter tube is about the size of a piece of spaghetti. And you have to thread that through the vocal cords of a moving, slippery infant while the clock is ticking. It requires immense skill.
It's incredible. We often think of birth as this, natural, ancient process, and it is. But the safety net we have built around it, this algorithm of dry, warm, stimulate, ventilate, it just transforms it.
That's the takeaway for me. It's the marriage of biology and engineering. The baby has this innate resilience. They want to survive. Their bodies are primed for this. But sometimes they get stuck. The protocol isn't about forcing them to live. It's about giving them a series of nudges to help them complete the journey they've already started.
It helps them flip the switch.
Exactly. It clears the path so the biology can take over.
I want to leave the listener with a thought about that APGAR score again. It's really profound when you think about it. It is the very first test we ever take. We are 60 seconds old. We haven't even opened our eyes properly yet. And we're being graded.
No pressure, right?
Right. We don't
Yeah.
study for it. We don't even know we're taking it.
Yeah.
Yet those 5 little numbers, pulse, grimace, activity, they dictate whether we get a cuddle or a shot of adrenaline. Kind of makes you wonder what your score was, doesn't it?
I have a feeling I lost a point on grimace. I'm not a morning person, and I definitely wasn't a morning baby.
I definitely lost points on appearance. I'm still working on that one.
Thanks for listening to this deep dive into the delivery room. It's a reminder that just getting here, just arriving, is the first great achievement of our lives. Stay curious, stay warm, and we'll catch you on the next one.